Hello, everyone. We are here today on the second day of the BSPRM trauma course, and I've got two of my clinical psychologists with us. So we have Hugh Green and we have Becky Rous. So they are both clinical neuropsychologists. They are senior clinical neuropsychologists, and we work together in the MTC. So we're going to talk briefly about the PTA, Post-Traumatic Amnesia, what it is, and what are the basic strategies to manage PTA patients in the MTC. So the opening question for both of you actually is, what do you think is the biggest misunderstanding about the PTA?
I think one thing that is worth emphasizing is the way that PTA is basically a transient state, right? So it's something that people go through, not unlike, in some ways, a delirium. So it's a state that's temporary, and then people pop out, as it were, the other side in a much more lucid and stable cognitive state. I guess because the word amnesia is in there, it's easy for it to get confused with the longer-term cognitive problems that people might have after a brain injury. But we can't really assess those longer-term problems until the PTA state has resolved. So I think the word amnesia can be confusing, because amnesia can be a symptom even when a person's emerged from the acute delirium-like state.
I was just going to add to that. I think also from what we were talking about in the talk earlier, often people might see the amnesia, but people might forget to think about all the other things. Mm-hmm. So it's really important to assess, a range of other areas. We're looking for changes in behaviour. Mm-hmm. We're looking for changes in other executive functioning skills as well.
So what do you think the duration and severity of PTA influence decision-making once people have come out of PTA?
So actually I start? I think there's so much in the literature, loads and loads of research out there that we know PTA is linked to how people function in the longer term, in terms of likelihood of getting back to work, likelihood of, longer term cognitive difficulties, long-term emotional difficulties, quality of life. So I think it's really, really important. And we need to really be kind of measuring accurately and then using that measurement to help guide our decision-making. So, if we know that someone's had a long period of PTA, we know that they're likely to need more rehabilitation and a longer time. And I guess we also have to be realistic and help manage families' expectations as well.
Thank you. Hugh, we have talked about the tools to assess PTA. Do you want to tell us briefly what sort of tools are there and what are their actually advantages and limitations?
So there's several different screens, and they all essentially center around the same sorts of questions. So they're asking people orientation questions. They're trying to establish whether people have internalized, have remembered information about where they are and why they're there. There's increasingly a move to trying to incorporate not only information about orientation, but also information about day-to-day carrying. So the Westmead uses pictures as well. So you will be asked to look at 3 different pictures and then recall them later on. The point being that it might be that a person can acquire this orientation information, but still be acutely struggling with memory. And so the Westmead's more sensitive than some of the other measures that have been used previously. We used to use the Galveston orientation and assessment or an attention test, the GOAT, but now the Westmead is more widely recommended. I suppose there's always an interesting trade-off between sensitivity and specificity. The problem with PTA in a way is that it's hard to know how to define it without the screening tools. They're quite an important tool in conceptualizing what it is, but it's not something to miss, PTA. So more sensitivity at the moment is probably better.
And it would be good to include a measure of agitation and behaviour, alongside it. Actually, I think that's actually really helpful.
That's very interesting. So once you have identified that somebody is in PTA, what sort of advice as a neuropsychologist would you give to the clinical team how to manage that patient?
Shall I start? And then you add, but education and advice, as you're mentioning, are the biggest starting point. You really need to give this to the team and the family, but we want to really think about having a low stimulation environment and reorientating in a kind of gentle way. So lots of clocks, calendars, really reorientating, familiarizing, and we want to work in a way that like minimizes any chance of agitation. So we want to like use like simple language, avoid triggering agitation. So just trying to help people be calm and just let them gently kind of recover.
And I suppose families are quite distressed to see relatives in a position of such extreme disorientation, and sometimes that triggers on the part of families well-meaning attempts to bombard the patient with questions or exercises or learning, and I think it'd be really reassuring to be told that this is a temporary state, and much as we want to give people some input, some stimulation, if we overdo it, that's likely to be too much for people. And so I think almost giving families an out, giving them the permission to step back and not be doing all of that very intensive stuff that can come up sometimes is important too.
So over the years, I mean, we've encountered patients together where people have been in prolonged PTA. So when do you start deciding whether, look, we need to actually stop measuring this because people are not moving forward and this is probably their new baseline?
Should I start? Yeah, so it's a clinical judgment. We have to use a clinical judgment. So there are times when it's very clear that someone will emerge, but there are lots of times, particularly in those more severe, moderate to severe cases, people will not be able to score out on the consistent scores needed to be deemed out of post-traumatic amnesia. So we have to look at if there's anyway, have they learned some new information? Do they know where their room is? Have they got a little bit of understanding of what's happened to them? So we need to look at the clinical picture and make a judgment and look at whether they've got any more longer term cognitive difficulties. So using kind of qualitative information of the family, and getting the picture together.
Mm-hmm. I suppose one thing that's important is the longer the PTA duration goes on, it might be that someone could be in PTA for months at a time, and then further down the line that will resolve and they'll be more lucid. And you can only really find that out retrospectively, but one thing you can say is the longer the PTA goes on, the chances are they're going to need more intensive cognitive rehab anyway. So it's worth, isn't it, beyond a certain point, and we often think in terms of maybe 6 weeks or 2 months. Once you've got to that point, a person's still scoring in PTA, the chances are you're going to need to for specialist cognitive rehab. Okay.
So are you aware of any recent research around the assessment and management of PTA? Or if you have a lot of money for research, what would be the one question that you would want to answer for these patients?
Well, I suppose what we really want to do is we assess PTA reasonably well now. It's always an ambition, isn't it, to try and help people and improve outcomes. And there's some emerging evidence, isn't there, that starting your rehab early while people are still in PTA can be useful. If you can do things to either shorten the duration of PTA or improve outcomes once the person's emerged, that would be something that would be worth having. So I think research that looked at doing more than what we conventionally do, that actually looked at whether active rehab can be useful, whether it's worth resourcing that early stages of rehab, that would be really useful.
And I think, just adding to that, I think if there's a way for some of the things that have come up in the things that have been discussed today, it's like the environment could be designed, resources could be used to make it better. I think you would see a shorter period of PTA, really.
So what you want is all singing, all dancing, yes, hospital for PTA patients.
Yes, they will.
Which is, wishful thinking, yes, but possible.
If you could shorten PTA, that would be shortening really the severity of the reducing the severity of the brain injury.
Yeah. Thank you very much.
Thank you.
And thank you for the talk.
Thank you.